My name is Dave Wheatman. I'm the Assistant Director for the Department of Pharmaceutical Care, and my primary charge is over the inpatient division. So I oversee the provision of clinical and operational services to anyone who's an inpatient. There's another Assistant Director who covers the outpatient areas, which are the clinics and the outpatient pharmacies and things like that. So between the two of us, we cover most of what goes on. We also have a person who's in charge of our Drug Information Center and Medication Use Evaluation Group. So from that, we have a director of pharmacy as well, and that keeps us pretty busy in terms of the trying to provide drugs and clinical services to the patients on a 24/7 basis. Are you guys worked with pharmacists before on patient care units and things like that? So not a new concept. So you're used to having a pharmacist during rounds and things like that. And okay, I hope you find them helpful. Okay, good. We try to be a pretty aggressive pharmacy department in terms of our roles and responsibilities for patient safety. I mean, we feel that if there's a medication issue, other than an adverse drug reaction, which we know, yes, these things can, these things happen. If you're infusing Taxol, at a certain rate, we know there's going to be infusion things. But anything in terms of medication safety, we do try to take as much of a role in keeping our patients safe and assisting you guys in terms of your process. That goes from beginning with the Epic build. We went up live with Epic. Have you guys seen Epic before? Used it in other facilities or something like it? Very active with the building of the order sets, with the building of the formulary. So we went through very specifically and took ownership of that to make sure that it is the way we want it. We have a great HCIS department, but that wasn't something we were willing to delegate to them or have them in charge of. So the way things you guys see orders, we've tried to design that to the best of our ability for you guys' input and working with. We've done a tremendous amount of work with the order sets. So when you have whatever patient and they fall into a pre-existing order set, we've tried to be involved with the build of that as much as we can, and we try to continue to make sure that the therapy that's being used is the literature-supported best practices. We try to identify owners of order sets as much as we can. If we see items that we think need to be discussed in terms of maybe different antibiotic coverage based on our antibiogram, or if it's something in cardiac measures, if there's new guidelines that are out there, we try to incorporate those things into that. Sometimes we're successful at finding order set owners. Sometimes we're not. We try not to make adjustments to them without at least trying to communicate with someone who's in the know. But at times, no one claims it, and then we'll go ahead and make the changes. So when you're interfacing with the order sets, they do change from time to time. Like I said, we don't try to do it willy-nilly, and we try to do it in a systematic fashion. Down through, obviously, the dispensing portion of things, we are totally compliant with USP 797, which is probably something that you guys have never heard of, but that's basically the latest and greatest guidelines in terms of production of sterile products. So everything we make that's IV is done in a clean room. People are gloved, garbed, booty. Air room, the air quality is monitored, it's controlled, and we have different air flows in different rooms. For regular products, we actually have positive pressure, so the air is always flowing out. For hazardous substances, chemo, and other things, we actually have negative pressure, and that air is externally vented. So, and we monitor our staff, fingertip tests, technique tests on a monthly basis, and we have an external company come to validate our procedures and our airflow. So, in terms of trying to make sure that we have a product that is as sterile as we can make it, that's pretty much where we are with that process. Obviously dispensing, getting products up to the floor, and also assisting with monitoring, and that goes, for aminoglycosides and for vancomycin and anything else. I'm trying to get my pharmacists to be more and more responsible and accountable for the drug outcomes that are being determined by the team. So if someone is choosing to use vancomycin, not only do we ensure that that's the right dose and the right drug up front based on what we know and parameters for use of that, but also to make sure when blood levels come back that we are running the kinetics to make sure are we where we need to be? Do we need a dosage adjustment? Do we need a frequency adjustment? Or do we need a drug adjustment? Then we'll consult you folks and say, hey, this is what we think, and then the dialogue begins from there. We do document our kinetics in the medical record, so if you're trying to figure out our recommendations, you can see exactly what we've created in terms of what we calculated for volume distribution and elimination rates and things like that. So we've tried to do that in a standardized fashion, so if you guys want to see that, or if pharmacist has not gotten hold of you yet but you want to see what's out there, you can pull that up as well. So like I said, we try to get as active as we can with the medication therapy and assist you guys in any manner that we can to help improve the safety of our patients. We are also very involved with the something called the Alaris pumps, which are the infusion pumps we use. We've worked on all the medication libraries, so if you get a norepinephrine bag, for example, there's a barcode on that bag. First, the nurse scans that, and that links into your order. So if you write an order for norepi, pharmacy verifies it automatically goes to the MAR. Then when the nurse picks up a bag and scans that bag, that goes backwards through the loop to say, okay, does this patient have an order for norepi? And if not, they'll get a warning that says, I don't know what you're doing, but this is not an approved order at this point. That's one barcode scan. The next barcode scan pulls up a medication library that is based on the infusion rates that are normally seen for that medication. So then the nurse, when she programs or he programs that information in, then if it's above a certain level, either below or above, they'll get an alert that says, this is a really low rate or this is a really high rate. Are you sure you want this rate? That's what's called a soft stop. It gives a warning. It'll allow the nurse to continue that infusion, but it's basically saying you're kind of 2 standard deviations or 1 standard deviation off from the normal. Then we also have something called a hard stop, where it will not allow the nurse to program in that infusion rate. So for example, for insulin, we have 2 entries, a 1 to 20 unit per hour and then a 20 to 100. So the typical patient's not going to use more than 20. So if you try to put in 50 units an hour, it will not allow you to use that within that library. So we've been very active in working with nursing to make sure that those libraries are up to date and used. Any of you guys in pediatrics? Okay. We struggle with peds just because they can have, 10-fold and on 10-fold dosing ranges in the PICU. You can have a 2-month-old and a 20-year-old, and it's tough to get all the ranges and the weights within one classification. So anyway, that's a little bit about us. We are open 24/7. We have a pharmacy that's basically dedicated, bless you, to adults, and that's on 4 Papa John. And they have all the medications that are needed there for the first doses of anything. Any type of product, if you prescribe it, if we need to get that dose to the patient right away, they are kind of geared for speed. They get the dose up and running, get the label printed, and out the door after they've done the other checks. We have the same type of situation up on 7 Papa John for our pediatric population. We have one more satellite dedicated to the OR, so they just handle transactions from the OR, making sure that we're keeping track of the controlled substances and making the drips that we can from there.
I just have one question. Sorry to interrupt.
No. It's better that way.
If they tell that for sepsis we have to have the antibiotics started within an hour.
Yep.
So if you put the order a stat in the Epic, how long does the medication come?
Basically, if you put in and you hit that stat designation, which is key, if you do the stat, all our medications within, we have pharmacists, we have 21 pharmacists throughout the institution during the day, Monday through Friday, and there's 5 of us during the evening, and then we have kind of a backup person. So if I have say you're, in internal medicine and you need a stat antibiotic, if my pharmacist who's looking at their queue, which means anytime anyone in those 2 floors writes an order, it shows up for them instantaneously, and they do the verification from that. If you write that stat, then it goes to the top of their queue and it's in red. And there's also a timer that goes with each order, so we know exactly how long it's been there. Now, if that pharmacist is tied up, say you write a stat order, but the pharmacist caring for that unit is discussing something with you down the hall and they don't have their laptop open, we have another pharmacist on the satellite who just watches that queue constantly. They're also checking products. So if they watch that queue and it gets to be about 5-6 minutes and no one's hit that stat, they'll call the pharmacist who's talking to you and say, hey, we got some stat antibiotics here, or a stat cardiovascular, or a stat potassium or magnesium. do you want me to take care of this, or do you have it? And then they'll have that quick conversation, and then they'll be waiting for that label. And then we have procedures built in that if we do get a stat, that the pharmacist cues that product up to the person in the hood, they're alerted that it's stat, and then they're standing there waiting for the product to be made, and then we hand deliver it straight up to the unit. We try not to tube anything that's stat. So we try to get it up there as quickly as we can. So we do have a mechanism built in for that. Our response time, we try to hit 10 minutes. It's probably 5-15 depending on what the situation is. That's for antibiotics. For other medications, you guys are familiar with Pyxis or AccuDose or that kind of concept? You know? So in every clinic and in every inpatient unit, we have something called an AccuDose station, which is, in a simplified way, it's an ATM machine for medications. So if you have a post-op patient who's in pain, you don't want to have to wait for the pharmacy to send a morphine syringe to be able to treat that. Nursing has a station where they can plug in, they can pull up the patient, and you prescribed that, say a 5 milligram morphine dose, they'll pull it up, and they can do something called an override. That means pharmacy has not reviewed the order, but nursing can access it. We limit that. It's a really strict list that we allow nursing to override, because basically what we're telling nursing is, you can do this, but you are on your own. You better check allergies, you better check age, weight, indication, and everything to make sure that that is what it needs to be, but you have access to that. It's only IV medications. It's just about every IV for pain, Benadryl if there's an allergic reaction, and other types of things. Yeah, Ativan, the other benzos, things like that, that if you really need it, Haldol in the psych units, that you can quickly have, or the nurse can quickly have access to that, and that's designed so we don't have too many stat things that we're kind of diluting ourselves and can't get that response time. Now, if there's ever a situation when you're not sure of what to do, there's no reason why you can't contact the pharmacist and say, this isn't really stat, but we want this in, say an hour. Tell that to the pharmacist, and the pharmacist will get things moving and make sure that gets processed. Probably the biggest frustration pharmacy has is communication, of trying to figure out what the priorities are, because we get hundreds and hundreds of orders in the queue every day from all sorts of units, and if the best thing you can do is say it's stat, because then we know and we have that system built in. If we don't get that communication, and then somebody says, well, half an hour's gone by, and we get the phone call from somebody's angry because we don't have the med, and, we're waiting for a procedure, or waiting for do this, and we just kind of throw up our hands and say, I got no idea. All right, we'll get it moving, but the more communication we can get, the better. But it's tough when you guys are writing so many orders and we're trying to process so many orders. And we're trying to work with the nurses too. I tell my staff that, every once in a while there probably is a stat DocuState. Because when you have a patient who's just riding the nurse around the unit, I want my DocuState, I have to have my DocuState, and then it's just driving the nurse nuts, just get her the DocuState as quick as we can. And just keep moving with other things. I have seen orders for stat multivites, and I have gone up and said, really? Seriously? Stat multivite? But they're pretty rare. Actually, I would think that the stat button on Epic is used less than it should be, or less frequently. It would help if it was probably used a little more. But, if it's stat, mark it stat, and we'll treat it as such. Because the expectations of my staff are we get it up there, within 20 minutes or 10 minutes or so, things like that. So, good question.
If I order medication as a stat, then the patient has to pay more than
No.
in order?
No. No. No.
That's why they order stat vitamin.
No, it's all the same. Yeah. The other aspect of things that are out there in terms of medications are emergency drug trays. So if you have a code, or even if it doesn't have to be a full-blown code, because there is no charge for opening up the emergency drug tray kit. Every floor has a medication box full of meds for a code, all the ACLS meds and some pediatric specific meds. And if there's a code, open the box. There's no charge for it. We'll send you another one, we'll replace it. Even if it's something that it's not a full-blown code, but you're heading towards the rapid response road, or you just need some magnesium right away to get you over a bad spot or whatever, It's in the kit. All the kits are standardized. Every one you open up is they're laid out the same exact way. So if you need something, open up the kit. There's this urban legend out there, and I've been here for 17 years, and it's never gone away, that the patients get charged more if you open up the code kit. So we try not to open it. No. I don't want to refill them any more than I have to, but if you need to use it, that's why we have people to refill it. So it's there's nothing there to worry about. We also have different type of kits for some very specific situations, like a transport kit. So if you have a patient in the ISS division or one of the critical care areas and they're going down to a procedure, they carry with them a kit of medications that if something goes wrong, they can administer that, and it's the same type of thing. Open it if you need it, and kind of go from there.
Can I quickly ask you, the code card, does it have magnesium and norepi as well, or that?
Yep.
You do have
Yeah.
FDA.
norepi?
Yep.
Levofed as well?
Yep.
Levo, it has the Levo.
Yep. I think there's 5 vials of 4 milligram per 4 mil Levofed in there. Now, let me jump back a second before I say that. And the first cart you open up doesn't have it. You guys have heard about drug shortages? They're real, and they exist here terribly. So there are times that if I can't get the drug into the institution, and for some reason not for some reason, it impacts the cheap generic drugs, and most everything in the code kit is a cheap generic drug like Epi, Mag, all that kind of stuff. If I don't have enough drug to replace the kits, we won't have it in the kit, and we'll put a note on the top that says call pharmacy. If you need to call us, we may have some or we may have none. It really depends on the situation, and the supplies of these things go up and down, and it's just been a nightmare for us. We try to, for those critical meds, we try to put as much supply out there. Or we try to reduce the supply that's there. So naloxone, I know we used to have 3 vials of it, now we have 1, which is enough to start you off, and then if you have to call pharmacy for more, we'll try to run more to you as quick as we can. But so any kit that we have, whether it's emergency drug tray or transport, we have anaphylaxis kit, we have a code green kit that has Haldol. 1 drug. Pull the Haldol out and use it. But those are there and available depending on where you guys are going to be in your situation. So, and if for some reason, if you would find yourself in a situation where you'd say, it'd really be nice to have this, call us and we'll take a look and see, hey, is this a situation where we need to create them? Because it's a fluid process. We create some and then some go away depending on what the prescribing issues are and practices are and where patients are. So it kind of floats throughout the year. So.
Do we any notification we're out of phosphorus?
That has probably been the toughest thing to deal with. We pretty much know the worst way to get a hold of you guys is email.
Okay.
I generally try to run it through my pharmacist on the units to bring it up in rounds. To make sure you get that message versus you, it's really hard. We do the best we can. I really don't want a situation where you need something right away and then pharmacy calls you back 5 minutes later and says we don't have it. That's a terrible time to find out if it's something that is needed. But we try to put a link up on the formulary handbook so you can see our inventory issues, and we try to update that. Right now, that list is 10 pages long of drugs that we are having trouble getting. So to try to have a crew of people to update it has just been a nightmare. And the problem is you order some of this stuff and it doesn't come in for 3 weeks and then you get 100. Well, okay, that lasts me for a week and now it's gone again. So how do I communicate that to you to say, hey, we got Norepi this week, but probably not next week. So and we really, keeping on that topic of the drug shortages, if there is a medication that we know which is very specific to a certain area, or it is ubiquitous, say dexamethasone, we'll try to pull in people from those areas to say, I have 150 dexamethasone vials left. This will last me, a normal use, it'll last me a week. And we'll have representatives from neuro and surgery and peds and whoever else is using it and basically say, what do you want me to do with the drug? We never want to be in the position of playing God with the drug. We want to work with the medical staff to say, where do you want it to go? And there's sometimes that the docs say, it can go anywhere, wherever it gets used, and we're out. Okay, there's other times where we specifically say we're only going to use this dexamethasone for neurosurgery patients and nobody else gets it. So if someone in another service tries to order it, we say it's reserved for this population. If that physician wants to use it, then we'll basically say, hey, please call the attending in this area and you work with them. And if they say, yeah, give them a vial, okay, here's the vial. But we try not to get in the middle of a discrepancy between that. We'll facilitate it and we'll work with the plan that's created, and we have a lot of input. You know, we work with other organizations and try to see how they survive these shortages and things like that. And we put a tremendous amount of time into it. But from what we hear, it is not going away anytime soon, unfortunately. Because it's not good for you, it's not good for the patients, it's not good for us, it's just bad. And unfortunately, none of the really expensive drugs are ever out of stock, so it doesn't help my budget. They're all the 2-cent vials of magnesium, not the $400 Argatroban vials. But anyway. All right, other questions? It's better for questions. If you have them, ask them. It's more interesting for you and for me.
What do you use for prophylaxis, DVT prophylaxis here?
DVT prophylaxis, we can use enoxaparin.
No.
I believe we have, I don't, dalteparin is not on the formulary, so it's enoxaparin.
And for renal failure, I think it's heparin, right? It's Q8.
Yeah, either we reduce the enoxaparin or you switch over to the heparin. Yep.
So, I don't know what consultation service you provide.
That's a good question. Right now we don't have a formal consultation service.
You do not.
We do not. But you can call us at any time you need a consultation.
Okay.
So there's no formal process where you go in Epic and you say, I'd like a pharmacist to look at that. Just pick up the phone and call the pharmacy or talk to your pharmacist, ask them what you need, and they'll do it for you. We've looked into creating something formal like that. Part of the issue is we don't know how big the ape is behind the door. If a little one comes out, hey, we can handle this, but if a huge one comes out, then we just get pummeled and we can't keep up, and then the service doesn't work. So we're trying to gauge, because that's not the first time that's come up, and we think that's a fantastic idea. We've started with the kinetics, just doing that automatically, so we wouldn't have to have a consultation service set up. In the world of kinetics, we also are trying to get to the point that pharmacy schedules the lab draws, because right now it's just been a mess. So what I'd really like to get to, say for Vanc or Gent, is you guys just say Vanc pharmacy to dose, and then we take care of the rest of it. We want to make sure that we have the guns to be able to do that 24/7. I can do that from like 7 in the morning till 10 o'clock at night, and then I get nervous from 10 to 7 in the morning. I don't have enough people to do it consistently, and if you guys delegate that responsibility to us, we need to be able to do it, and I want to make sure we can do it before we take that next step. So we're breaking it into incremental steps to kind of get there. But in terms of answering your question, whatever, if you need any question in terms of drug use, side effects, alternative therapies, whatever, just call the pharmacist, they'll help you out. We have, I have a crew of clinical specialists, about 12 of them, who are very focused in certain areas like cardiology, ID, transplant, things like that. And then I have a whole bunch of other clinical pharmacists. So the clinical pharmacists, if they get the question, they can answer it for you, great. If they can't, they'll go to their clinical specialist, and who's kind of the expert in that area, and they'll try to get that answer for you. Now, if they can't answer it, or the question is a little more, requires them a little more research, we can go down to the Drug Information Center, and you guys have access to that. It's open 8 to 4:30 every day, or Monday through Friday. So if you need any type of drug information and you can't find it at Micromedics, or you just want someone to talk to, all they do all day is answer drug information questions. There's a person in a room about this size, full of books, full of computers. They have a couple students and a couple of pharmacy residents working with them. And when your question comes down, they'll try to answer it to the best of their ability. And they will go through any length, and they have available to them every source pretty much that's reliable and available, and they will try to get that answer. They'll call drug companies, they'll call also, manufacturers, they'll call wholesalers, they'll call, other hospitals. They'll do whatever they can to try to get you an answer. One thing they will get from you before they get you off the phone is they want to know what the question is. They will needle you to figure out exactly what is your question. So if it was, how do I dose Vanc? No. they're not going to accept that. They're like, who, what, where, why, what is the indication, what are the symptoms that they want, because they will give you an answer if it exists. If they can't find the answer, they will basically say, we don't think it exists. They'll search primary literature, secondary literature, they'll pull articles from the health science library. I mean, these people, the little nuts. I mean, that job would just drive me crazy, but they love it, and they will get you an answer, and generally in a pretty quick manner too. So.
But a pharmacist is available in the night as well, right?
Yep, 24/7. So if you're here at 11 o'clock at night and you have a question, those pharmacists will try to answer the question to the best of their ability, and they have access to Micromedics and a whole bunch of other online resources, and they'll try to do what they can to get that answered. If not, we have a clinical specialist who covers 24/7, who's available by pager, and they also have a manager who's available on pager 24/7. So if the question's beyond their capability, they will call and say, hey, I need some help with this one, and then we'll keep calling until we can try to find someone who knows the answer to the question.
And this, I think the main problem, as you were telling, was with the gent and especially the bank dosing and the troughs and all that.
Yep.
So does somebody keep a tab on the dosages and the trough levels
Yep.
on top of us, or?
Yep, absolutely. Yeah. So they'll watch that. Every pharmacist, when they're on their queue, will take a look and they'll say, okay, who do I have on bank today and what levels are coming back? And they'll be monitoring. We call them high alert meds, and it's also called a selective monitoring system, where people on heparin, bank, warfarin, gent, phenytoin, and anyone on chemo, we're looking at the set parameter of laboratory measures that we need to on a daily basis, just to make sure that if levels are coming back, then we can react to them. And also, if nothing has come back, if somebody's been on bank and it's been 7-8 days, then we'll say, hey, can we check a serum creatinine, or just kind of check in to say, do we still need the bank, or kind of educate themselves on that, and then see what we can do from that point of view. So
even though you're not consulting you guys, but you keep giving input.
You got it.
Where can I check your comment and recommendation? The MAR?
Right in the progress note. So for the kinetics, it'll be right there under pharmacy, under a progress note. It'll be right then and there. So the other service that we provide is gathering medication history from a patient upon admission. We are trying to get to every patient within 24 hours. We've been doing this for probably 5-6 years now. When we first started, we tried to actually get a med history list before you guys created inpatient orders. We could never beat you to the orders. Whether they came through a clinic or came through the emergency room, we could never get to the patient before you guys were actually creating the order. So we abandoned that and said, listen, you guys write your orders for admission, then we're going to go back in and we're going to talk to the patient. We're going to do medication history, and we'll talk through what that patient med list is. And they're very, very thorough. If the patient says, well, I'm taking furosemide, I'm taking an allopril, and then I take a little white one for, I don't know, something, and I take a purple one when my head hurts, and so they'll say, oh, okay, who's your local pharmacy? And then they'll call the local pharmacy and says, listen, I think we got colchicine for gout. Can you double check? Because they said it's for their toe when it hurts, and they take something for their stomach. I think it's Prilosec. Do you have a record of that? Try to give you guys at least retrospectively, a full medication list. And then if we notice that there are issues, after you guys have written those orders, we'll call you if it's something like, we call the pharmacist and say, hey, did you know they're on warfarin too? I don't know if they're pre-op or not, or whatever the deal is, but they say they're on warfarin, and then we can have that discussion of what does the local pharmacy say. And you guys know it just as well as us. You get into a whole crazy world of what patients are really taking and what they're not. The nice thing about that process is, so we take a medication history and then we do the medication reconciliation. The nice thing about when that's completed, it sets you guys up for a discharge. So when you guys are looking at your inpatient list and your outpatient list and creating that discharge summary, that at least you guys have the best information that's we can get, and to set you guys up for that.
This is for every patient who walks in?
Every patient.
Oh, that's perfect.
We're probably at 90% success rate right now based on the staffing I have, but so that's what our goal is. Yeah,
somebody else is checking on.
Yeah, right. And we have students obtaining med histories for us as well, and checking them. So we're trying to get those folks involved for us and get as much as we can to you guys. Because one of the problems that we have here is our discharge summary lists are terrible. If you haven't heard that yet, they're
You guys
terrible.
reviewing the discharge reconciliation, yeah?
No, we're going to start. I'm going to start having my pharmacists do it on transfers to facilities. I just don't have the horses to do it on every patient. I wish I did. I'm asking, and every day I get more and more ammunition, but pharmacists aren't cheap, so it's tough. I probably need another 10, to make sure I get my 100% of med histories and 100% of discharge summaries, but it's a great area for us. I love to the point where, you guys say, or we hear the patient's going home, I'd love to set it up for you, to be honest. I'd love to sit down and say, okay, this patient is here, they're ortho patient and a hip surgery or whatever, and we look at the home med list and we look at this and we set up a discharge med list and we hand it right to you and you guys say yes, yes, no, no, talk about it and boom, then we can facilitate the scripts. The other service that we're starting to provide along with that is we're starting in some pilot areas to do a bedside medication discharge service. We actually bring the meds to the patient at the bedside and we do the consultation right then and there. It's a nightmare for us in terms of trying to coordinate with the med lists and when the scripts are written and where they go. The Epic computer system does not facilitate this well, so we spend a lot of time chasing their tail. But the patients absolutely love it, because they can sit, they don't have to go and wait in a queue at a pharmacy, they don't have to go to Walgreens, anything like that. And it's good, it's revenue for the hospital, it's a great service for the patient. The patient satisfaction scores on the units we've done it have increased. It's a good service, it's just a lot of work. And as we get into the realm of more and more prior authorization requirements for every medication being prescribed, it just takes more and more time. But that's a good thing. So we do offer a prescription service here. The patients have the choice. They can have their prescriptions filled wherever they want to. If they want to go to the local pharmacy, they're more than welcome to do that. We would love the opportunity to fill the scripts here, but it's really their choice. There are some situations where we do recommend they get at least the initial prescriptions filled here, and that is if it's a medication that's not common, if it's really expensive medication that the local pharmacy, if you send someone out on today, for example, they discharge at 2 in the afternoon. By the time they get back across the western part of Iowa, their pharmacy may be closed, or they get there within an hour, and the pharmacist says, "I don't keep this med. I can order it. It can be here Monday, but I don't keep it right now." If they do the first script here, then we transfer that script out to their pharmacy, and they can have it continue to fill there. I know we don't have peds folks here, but it's probably bigger in the pediatric world. Or in the adult side of things for oral liquids. We've done a lot of research into different compounds to get oral tablets into oral liquid formulations. A lot of local pharmacies don't have that information. So we say, let us fill the first one here, and then we'll send that formulation, or the prescription and the directions on how to make the oral liquid out to the local pharmacy and say, this is how we do it, and at least the patient can start their therapy. More than once have we had a patient readmitted within 24 hours because they couldn't get their script filled and they just didn't think it was important, and they're back here for no good reason. So we try to avoid that as much as possible. We have been involved with the build of the outpatient system as well, so we've tried to create that so it's as easy flowing for you guys to set up your script as possible. But once again, if you have any questions, call your pharmacist and they'll help walk you through. We have a facility called the Medication Assistance Center, which we have 1 or 2 pharmacists who do nothing other than assist patients who are having trouble affording their medications. They work with manufacturers, and they have patient assistance programs, or we look at the regimens that have been prescribed and we say, hey, maybe we can try this, or maybe we can try this, and then we would be in consultation back with the physician to say, hey, the patient is telling us they can't afford this stuff. Here's a couple options. What do you think? And if you say, yeah, we can switch to that, okay, we'll facilitate getting those scripts written. And if you say, no, they really can't switch to this other medication or whatever, then we tell the patient, listen, this is what we are. But at least we know ahead of time, and we can consult you guys so hey, your patient is going to have issues going home with these meds, and you can kind of be on top of that, and sometimes there's things that can be done and sometimes there's not, and just have to kind of work it through. So questions on any of those things?
Antibiotics guidelines, where can I go?
We publish, I think it's on a yearly basis, if not it's about every year and a half, something called the Antibiogram.
I can just get pocket card.
Yep.
Stuff.
It's a pocket card. Yep, we'll get you that. I should have brought those. It's all in the formulary handbook, but I'll get you those. Are you guys done after this, or are you here for the rest of the afternoon?
Until I think 5.
Oh, okay. So I'll go down and get some copies of those. I should have brought them. It's a good idea. And I'll show you that, the guidelines and the sensitivities and things like that, and what's resistant and what's available. And we have a ID consultation service here that has a pharmacist a part of it. So, if you're looking, if you have a situation where you have some questions that are very specific to antibiotics, if the floor pharmacist can help you, great. If not, they'll contact that specialist and say, hey, I'm not convinced I know the answer here. What can you say? And then they'll, kind of get them involved with that. So,
Are there any things that needs an ID consult to order?
we don't. We haven't gone down that route in terms of things that are,
Awesome.
have to have. We do have some medications that are restricted to an attending physician and a service. So if you guys being attendings, if you guys can use any medication you want, the only thing that pharmacy asks you to do is fill out a form. It's called a 602, which is called a special order medication. So let me jump back a second. If there's, we have a formulary and we try to stick to the meds on the formulary, but if you guys have a situation where you need a medication that's not on the formulary, then you fill out this form and we'll try to get the drugs to you within 48 hours. Generally we can get them quicker than that, but there's sometimes that, we've had times when we have to call Cleveland to get a medication, and literally by the time they get it on a bus or a plane or something to get it out here, it takes 48 hours to get the drug. We would call you guys back and say, this is going to be a while. If there's another alternative, let's go with that, but we should have the drug by this time. That's basically just a form that helps us track, as if you order it and you order it and you order it, we go back to the Drug Information Center and say, you know what, we've had this request a couple times now, either add it to the formulary or we need to have a discussion of why are we using this. And it happens every year in terms of trying to evaluate those things. Now if you're on a service, you want to use a medication that's restricted to cardiology and you're working in internal medicine, if you guys feel you need that drug as the attendings, you can sign that form and say, yeah, I'm taking responsibility for this. I understand that, this is restricted to these units, but my patient needs these type of conditions. We'll go ahead and get that out and dispense it. We may suggest you get a consult depending on what the restrictions to the drugs are, and at least make sure you guys understand why some of those restrictions are put in place. But clinically, if that's what the patient needs, and after the discussions have taken place, then we can go from there. That doesn't come up that frequently either. We try to be pretty proactive in terms of saying, if we're going to need this, let's get it on formulary, and if not, we'll try to clearly delineate why. But it happens every once in a while. There are some medications that are not on formulary that we actually have a supply of because we're in the process of evaluating it, or you have to buy the stuff in a box of 20, and the last time we ordered it we had 2. So we can send it down, we check the store room, and there's 18 of them left, and we get it right up and running. So those type of situations exist as well. So there are some medications, and mainly these are biocheck drugs or chemo or things like that we have on formulary that we don't stock because they're expensive. If it's $20,000 a dose and it's not a stat medication, we'll basically say, hey, we'll work with you guys way ahead of time in the areas that you're staffing and say, hey, if you want this drug, let us know a patient's coming in tomorrow. We'll go ahead and order the drug and get it in, but generally we're not going to stock it. And these are usually, like I said, chemo agents that are second or third line that we may only use once a year, but to have $40,000 worth of inventory sit on the shelf and expire, and the companies know that and they won't take those back, so it's taking a nice car and throwing it in the swamp and moving on. So we try not to do that. And medications get expensive. Like I said, the expensive ones are never on shortage. They're always available. It's the cheap ones that are the problem. So, all right, other questions about anything? So I gave you a copy of this guy, and I don't necessarily want to walk through this verbatim because you'd all fall asleep. I might fall asleep too going through it, but I'll just hit a couple high points. It kind of goes through some of the medication requirements, and obviously these are, in terms of name and hospital number, age and sex and things like that. That's all built into the system. We will check to make sure that there's allergy information. Our system currently will allow you to enter a medication order without allergy information being present. We had a lot of conversations on that. Is that the safest thing to do? And, kind of determine, well, if you're in the emergency room or somewhere else and somebody comes in emergently and you have to start drugs and you can't get allergy information, being locked out of the system is not a good idea. So just recognize if you write orders, they can go through without allergy information. Now, pharmacy generally tries to stop that, and go up, talk to the patient, talk to the nurse, talk to a family member, and try to get that information as quickly as we can. And we actually have some reports that are running in the background that say, hey, this patient has been out without allergy information for X amount of time. Somebody needs to go get it and figure out what's going on. Those type of things. But you can put that information in there.
Quick question.
Yeah.
So sometimes it's not a true allergy. Somebody might have nausea, the ciprofloxacin, and how do you override it if I want to give, say, IV ciprofloxacin, something like that?
Yeah, if that pops up, you do exactly that. You can override it. What would be great if you put in a reason to say not a true allergy. There are no commercial systems out there right now that have a true differentiation between an adverse reaction or a side effect and an allergy. All the systems are built the same way because they don't want to take the liability. Codeine and nausea is the classic one, and your example is a good one too. We try to put notes in the allergy field, so it still may come up codeine, but we'll put in a note. So if the allergy does pop up on a subsequent med, we'll take a look at it and say, yeah, okay, we've seen this, and we move on. But yeah, Epic isn't good at it, but nobody is good at it. So the only way to do it is start gaming the system, and we didn't want to do that because sure enough, somebody's going to get burned. Someone's going to have a true allergy to something, and we're going to miss it because somebody thought it was just nausea, and we'd rather err on the side of being conservative. But yeah, and that does pop up those alerts, and they can be frustrating. They flash for you and they flash for us as well. So, and they actually flash for nursing too. So everybody's one situation can fire 3 different alerts to 3 different groups. Okay, so all the current medications are listed in there, and like I said, when you guys write an order, pharmacy does the verification. That processes right over to the MAR. Nursing will see the medication on the MAR prior to pharmacy verifying it, so they can still act on something. And if it's an overridable medication for pain and that all works out, that's a good thing. If it's a medication they steal from another patient and administer it prior to us verifying it and it wasn't the right med, that's a bad thing. So we try to work with nursing to say there's a little stop sign there. That means we haven't seen it. Unless it's stat, don't give it, because we could be in the process of contacting you guys to say, hey, should we think about something else, or I'm not convinced about this dose, or whatever we're holding it up for. And nursing is pretty good with that most of the time. Medication abbreviations, with the electronic system, it's pretty much taken that out in terms of your ability to write, an abbreviation with the paper. That was an issue, and the Joint Commission was all over it. Now that's not really a problem. So that's kind of taken care of itself. I talked a little bit about order sets before. If you guys find yourself in wanting to create an order set, you have a patient population that you're ordering the same type of meds and the same type of labs, there's a lot of people who will help you with that. Pharmacy will get involved with the pharmacy portion of it, and laboratory people will get involved with that. We have way too many order sets. I think when we went up with the system, we were over 4,000. I think we probably have 2,000 that are active. I think Wisconsin, last time we checked, had like 1,700. So we really, really went overboard. And we've been in the process of trying to eliminate those. If nobody's used it in 2 years, we're getting rid of it, unless it's some kind of crazy anaphylactic situation where, it's a good thing we're not using it, but it's there if we need it. Let's see. Anyone here going to be involved with chemotherapy?
Yeah.
Okay, so we have policy and procedures set up with chemo, and Epic has the whole Beacon module that is set up with that. We've spent a lot of time building those things. the thing that I've been surprised on in terms of the oncology world is how frequently the order sets change or how frequently the protocols change. So we're in the process of trying to kind of strengthen our system to make sure that anytime there is an order set or protocol change that we have a double check on the process before we have to use it, or if we have to do it once. You read something in a journal article and you have a patient that matches that, but we don't have an Epic order set built for it. You got to be careful, because if you start foraging through order sets to find something that kind of matches what you want, remember that comes with all the other labs and all the other instructions. So we've had physicians who have changed it to match the drugs, but everything else downstream doesn't make any sense. So everything gets set up and it's a Friday afternoon and it's great, and Saturday morning everything hits the fan because nobody can figure out what's going on. So we're trying to keep up with that, but it's been a challenge. Investigational medications or study medications, pharmacy oversees all these, whether they're provided by the investigator or not. So if there is any type of study, we will maintain the supply. We'll track accountability records if needed, and all that obviously goes to the IRB and things like that. And if you're into those type of things, there's a couple pages that you can read in terms of the drug therapy. And just by the way, we've tried to move our things to more hospital-wide policies regarding medications, not pharmacy policies, because nursing is really fond of saying, well, that's a pharmacy policy. No, it's not. It's a med policy. You're using the meds as much as the doc is, as much as we are. But we try to make this universal, and this is posted on the LAN. You'll probably never see it again, but if something comes up, I know where it is. So, all right. Orders for compounded drugs or drug mixtures not commercially available. We do have situations where every once in a while we have a request to bring in a drug from another country or something that's not approved by the FDA. And we have some pretty strict guidelines we go by to ensure that if we have to do it, and every once in a while, there's a situation where we have to do it, we go through a patient consent and a whole process through hospital legal to say this is what we're going to do, and so the patient knows what's going on, and we're trying to be above board as much as we can. But it does happen, and we have a mechanism to address that when it does. Let's see, we dispense generics unless requested otherwise, and most times still we'll dispense generics, because that's what we have, unless there's some crazy thing with the drug. Even levothyroxine, these days we're doing generic. DIG, we do generic. It used to be DIG had to be brand, or the thyroids have to be brand, no more. So keep that in mind. Let's see, we do parenteral nutrition solutions for neonates, pediatric patients, and adults.
We order them.
There's a standard order sheet that'll go through and it'll walk you through all the issues, and I think it actually brings up the previous TPN, and then you can make adjustments from that. We accept them anytime from 7 o'clock in the morning through about 9 o'clock at night. If we know a patient's on a CVN and we haven't received it by about 3 in the afternoon, we'll start calling you saying, do you need a CVN today? And we'll double check with the nurse. If we can't get a hold of you, we'll continue to try some mechanism to see if you still want it. If we get to about 9 o'clock, we pull the equipment down because we got to get it cleaned and ready for the next day. To reset up the equipment is a good $500 upstart to re-plug every bottle and all the tubing. So we pretty much say, listen, we tried to call you 6 times. If we don't have the order, then we're not going to make it for you. We'll give you a bag of D10. We'll make electrolyte combinations for you. We'll do whatever we can to get you through to the next day. And when the machines are up again, then we'll make you a 12-hour bag or whatever we have to do. Once again, that's pretty rare that those situations occur. Now it's actually easier for you guys because you don't have to go look for a form. Wherever you are on a lap, on a computer, that stuff will come right up for you. You can see what you ordered the previous day and go from there. Hard stops. Are you guys familiar with the concept in an electronic system of a hard stop? We really have reduced the amount of hard stops we have just to what's listed on page 14. And these are either things that are out there because of FDA mandates or potential for adverse effects with extended use. In some cases, it's high cost therapy. So these are ones that, and you got to remember that when a hard stop occurs, it falls off the MAR. So it runs, say if you're using phenoldiprem, 48 hours after that, it falls off the MAR. Nursing is driven by the MAR. So when they look at their MAR sheet, if they see a drug, they'll see the due time, they'll give it. If it's not on that MAR sheet, unless you got a real sharp nurse, they won't see it, they won't request it. And it's fallen off the pharmacy record too. So if it's something that you wanted to continue, so this list is kind of important for you guys to be aware of if you're in these type of situations, that it will fall off. And we know that when we converted from the paper system over to the electronic system, we had a couple antibiotics that were on hard stops and they stopped and nobody picked it up for a little while, and it was a little bit of a problem. Everything else is what's called a soft stop. So systemic antibiotics, and it starts on page 15 and goes over to antiretrovirals, tuberculosis, things like that. Where there, in your navigator system, you're actually getting a prompt that's saying, hey, it's been 7 days here, do you want to take a look at this? Or it's been 30 days. So it's not going to make it fall off the MAR. Pharmacy's still going to batch send it out, but it's kind of giving you a prompt. Obviously the antibiotics are probably the most important thing there to say, hey, we've been doing this for 7 days. Is this still the therapy you want? And I would hope that I got a pharmacist standing behind you pulling on your coat saying, what are we doing with the antibiotic therapy? I hope they bug you with that in a sense, in a polite and tactful way, but they're kind of always asking, where is the therapy, where are we going, what's the plan? So they can kind of keep up with that. Let's see, blanket orders, we can't use blanket orders. You can't say resume all previous meds, you have to write them all out. Obviously when a patient's admitted, you can use the home meds that were in the system before. But you got to be really careful using anything in the home med list the pharmacist hasn't touched, because a lot of times MAs do them in the clinics. And if a patient says, are you on metoprolol? And the patient says, yeah, I take one of them, and they'll open the system, and if they say, well, 50 is a choice, they'll put 50, whether your patient's taken 100 or 25. In the last 2 weeks, we've had 2 errors where one MA asked the patient the dose of furosemide. They said 20, and they said great. They put in 20 tablets of the 20 milligram dose. So when the order converted over, it said 400 milligrams. So when the physician wrote that, my pharmacist called and said, 400 milligrams oral? It's like a fistful of tablets. I mean, really? And they said, no, I didn't write that. I'm like, yeah, you did. And they're like, and then we went back and we chased it all the way down to it was an MA, and that's how that started. The doc got set up because it said 20 tabs instead of 20 milligrams, so we've tried to eliminate that. The next situation was and this happened just last week, where the patient was on captopril 25 milligrams, but they were actually only taking 25 or 12 and they were written for captopril 12 and a They were written for captopril 25, but they were really only taking 12 and a half. So when the MA took the history, they said, well, you've been prescribed 25, so that's what I'm going to put in. So when the physician went to do the admission, they didn't see the note that the MA left, which is a crummy place to leave it. So they converted it over, and we didn't figure it out until the patient had a rapid response called because their blood pressure had bottomed out. So even though the patient had told them this is a situation, it didn't get recorded. So when you're pulling a med history from a patient who's been in a clinic, you just got to put a little time into it, because if it's coming from an MA, and I'm not trying to bash MAs, I'm just saying the last time in the 2 weeks we've had 2 different situations with this, and it's just one of those things that's been problematic. Am I out of time?
You can finish up.
Okay. Let's see. 2 other areas that currently pharmacy is working on to stay in the good graces of the Joint Commission is therapeutic duplication and titration orders. So basically in terms of therapeutic duplication, if a patient has a situation where they have, say, injectable morphine and injectable hydromorphone, and they're both for severe pain, the Joint Commission is basically saying there's not enough guidance for nursing, because if there's no guidance or if the guidance is duplicate, it's basically saying nursing is prescribing. and they have been citing hospitals on this. So we have been trying to go through and put in parameters the best we can to say either for severe pain or mild pain or moderate pain or some type, for breakthrough pain if they're on a PCA. So we've gone through as many order sets as we possibly can to try to alter these so it's already done for you. The problem is if you use an order set and that's all done, and then somebody else comes in from the side and writes another order for something else that is now in duplication of the previous ones, now we have a problem. If the Joint Commission finds that, we're going to get cited. And it does leave the patient at risk because if some of the nurses out there are just absolute rock stars, especially the ones in oncology where they deal with this a lot and they're very good at the pain management theory and they know exactly what to do. There's no worries. In other areas of the hospital where they're not accustomed to it, we've had trouble with someone who received several forms of an opiate, and now we have call a code or rapid response because we have trouble and we go back and figure out that, well, in the last hour they received morphine, hydromorphone, Tylenol with codeine, a Percocet, a straight oxycodone, and they just put on a fentanyl patch. So it's just an absolute disaster. So we're trying to eliminate those. So I've asked my staff that if they, once you see an order and they're verifying an order for, say, morphine, they're going to look at the other profiles and they're going to see, is there anything else that there's a duplicate, and then call the resident and say, hey, I need some clarification here. I can't do both. So that's one of them. The other is titration or taper orders, especially in the ICUs. We've tried to go through and put a starting dose for every single medication. So every norepi should have a starting dose. And then they should also have a titration dose to say, and the goal therapy. So you're going to start at this, you're going to go to this, and you're going to titrate up through these steps. So that should be built into every one of those orders so nursing knows exactly how to act. So, am I out of time now? I think I am.
How much do you have left, do you think?
I can be done. I just asked you guys if you have any questions about anything. Anything that you've seen from other pharmacy departments that you wonder if we do, or other pharmacy departments do that you don't want us to do, or?
I'm a little bit confused by the TPN.
Yep.
I mean, so the hospital I used to work in, there's Penn Lab. This is a separate department than pharmacy. So in this hospital, the pharmacy is taking care of everything related to TPN.
Correct.
Okay.
So we create them all. Well, we make, once you order it, we actually, in our facility over in Boyd Tower on the 7th floor, we generate all the TPNs. So we can make whatever you want, but we just make them here. We don't subcontract out to anybody else. We don't trust anybody else.
So then we don't have a nutrition support consultation. Anything
We
like
don't.
this?
We don't have other.
Nutritionists or anything.
There's some dietitians, clinical dietitians that would offer services for you, but we don't have a consult team that would have multiple members on it. So if you needed a consult, there's clinical dietitians who could help you. I have no idea how to get a hold of those guys, but the folks on the floor will.
But the doctor who ordered TPN is myself.
Correct.
Okay.
Yeah.
Using
got
order
it.
sets, right?
You got it.
TPN order sets.
You got it.
So I think there is a dietitian. If you call her and say this patient needs TPN, in 2-3 hours you'll find a note with all of the details. Usually they calculate with what kind of amino acid concentration, D50, and all of that, and usually they have it within a couple of hours.
Then they posting the
Yeah, they have a note
recommendation.
in for you. So.
And they're just following that, the recommendation in the orders.
Yeah. All right. Any other questions for me? Well, it's been a pleasure. Good luck, guys.
Thank you.